Welcome to PB&J number 90. Today we are covering asthma in pregnancy. I hope you got a chuckle too of the House MD inhaler. Don't forget to subscribe and check the description for more resources. It's safer to treat asthma in pregnancy than to risk an exacerbation in the hospital. The ultimate goal of managing asthma in pregnancy is maintaining adequate oxygenation of the fetus. Uncontrolled asthma can lead to maternal hypoxia, reduced oxygen saturation, and decreased placental oxygen transfer. This can result in fetal hypoxia, growth restriction, preeclampsia, and morbidity. Your patient asks you, "Will my asthma get worse in pregnancy?" You can tell them the rule of thirds, say that a third improve, another third worsen, and the last third remain stable. Not really helpful, right? Well, due to it potentially worsening, proactive surveillance is mandatory. Monitoring includes subjective symptom observation and objective checks like peak expiratory flow rate or forced expiratory volume in 1 second. I think of FEV1 like the indicator of lung function. The higher the number, the better the lungs are functioning. Another presentation to triage may be dyspnea of pregnancy. To differentiate these two, dyspnea of pregnancy lacks cough, wheezing, or chest tightness, and it would not get better with asthma treatment. Asthma is categorized as intermittent, mild, moderate, or severe persistent based on FEV1 percentages, symptom frequency, nighttime symptoms, and activity limitation. Note that severity is assessed in patients not on controller medications, while control is assessed in those on controller meds to guide therapy adjustments. Okay, so if you can remember anything for treating asthma, it's rescue therapy with albuterol and controller therapy, typically with inhaled corticosteroids. Budesonide is the preferred ICS. The next slide will cover the step up and down therapy ladder. This is a slide to screenshot or memorize. Step therapy in pregnancy escalates care from intermittent, treated with PRN albuterol, to mild, moderate, and severe persistent asthma, which requires a combination of ICS, LABA, and sometimes oral corticosteroids. If a question asks you when you can perform step-down therapy, note that it is often postponed until postpartum to avoid an exacerbation. Antenatal fetal surveillance is needed for patients with poorly controlled, moderate to severe asthma, or those recovering from a severe exacerbation. Initiate serial ultrasound examinations start at 32 weeks. A decrease in fetal movement during a maternal exacerbation is a red flag trigger for immediate medical attention. We triage asthma based on FEV1 or PEFR and fetal status. Patients with FEV1 or PEFR 70% or more sustained for 60 minutes are discharged. Those between 50 to 69% require observation or admission, and those below 50% or with severe symptoms need admission most likely to the ICU. A normal or elevated PCO2 greater than 42 millimeters mercury in a pregnant patient should be admitted to the ICU, as it is a sign of impending respiratory failure due to the baseline respiratory alkalosis of pregnancy. How do you discharge a patient after an exacerbation? The bundle includes a rescue SABA, an acute burst of oral corticosteroids, and a controller reset by continuing or initiating an inhaled corticosteroid. Don't forget to schedule an outpatient follow-up within 5 days of the triage visit. In the intrapartum period, medications must be carefully chosen. Magnesium sulfate and prostaglandin E1 and E2 are safe bronchodilating agents. Unsafe bronchospastic agents to avoid include carboprost, ergonovine or methergine, non-selective beta blockers, and indomethacin in aspirin-sensitive asthmatics. Intrapartum management involves 4 steps. Step 1, maintenance of routine asthma medications. Step 2, preferred anesthesia is lumbar epidural. Step 3, stress dose steroids are administered for women on systemic corticosteroids. Step 4, cesarean delivery is rarely necessary and is reserved for acute exacerbations requiring aggressive medical management. Let's briefly talk about postpartum care. Breastfeeding is safe, as only minimal amounts of asthma medications enter breast milk. Approved medications include prednisone, inhaled corticosteroids, and beta-2 agonists. Environmental control helps minimize postpartum medication requirements. When in doubt, escalate controller therapy. Here is our high-yield pearls. I'd recommend you pausing to take a quick read. Let's dive into some practice questions. I'll have you pause and read the question, and the next slide will include the answer and explanation. Next question. I'll have you pause and read the question, and the next slide will include the answer and explanation. The correct answer is C, adding salmeterol to the current low-dose budesonide regimen. Think about to that step therapy ladder. Uncontrolled asthma on low-dose inhaled corticosteroid requires stepping up to low-dose ICS plus a LABA. Salmeterol is the preferred add-on, as it is more effective than LTRAs or theophylline. Remember that immunotherapy is not initiated in pregnancy. Final question. I'll have you pause and read the question, and the next slide will include the answer and explanation. The correct answer is C. Recent systemic corticosteroid use causes HPA axis suppression. We give stress dose steroids during labor and 24 hours postpartum to prevent an adrenal crisis. Thanks for watching PB&J. If this made asthma feel more manageable, please hit the subscribe button for more high-yield reviews. Until next time.